Okay, it's been recorded now. Okay, it's not a lecture, right? It's not a lecture. It's a discussion. So I want you to contribute as well. Okay. So wait. Are you able to see the video or not the video? The presenting slide, short case cyanotic heart disease?
Yes, sir.
Yes. Okay. So we'll go directly to the video. I'll come back to this later. Okay. Right. Okay. So you can now see a child who is somewhere around, say, 6 months or 8 months old child who is lying in the bed, and our registrar is going to check the cardiovascular system examination. So if you are faced with a child like this in your real day-to-day life, what are the first things you will do before you go for the cardiovascular system? Can someone tell me what are the things which you need to know or which you need to observe regarding the cardiovascular system in this child? Any input? You can talk freely. No one will be penalizing you for talking.
So observe whether there is any signs of cyanosis, central or peripheral cyanosis.
Okay, so you are talking about general examination, right? Like cyanosis.
Yes, starting from the general.
Right. Okay. That is one thing, right? Regarding cardiovascular system, there are things you need to check for, like cyanosis, whether the child is pale, and especially in an infant, whether the child is having any signs of distress. Now, when you look at this child, you can see that although you can't see this is only a still picture, but still you can see that the child looks fairly comfortable. And at the moment, there's no obvious cyanosis from a distance, right? The second thing is whether the child has grown well, right? You need to know whether this child has grown properly. By roughly looking at him, you can see that he has very nice round arms. The cheeks are very chubby. Okay, there's no signs of wasting. And also he has a nice bundy, there's no features of wasting in this child. He looked like a fairly grown up child for the age. Now this child was, if I can remember, somewhere around 8 months. Right? So these are very important things before you go to the cardiovascular system problem. So we will listen to the registrar and see what she's talking about. Okay, so she mentioned that she would like to check the weight and length, and importantly, check with the Septal charts, right? Just by getting the weight and length, you can't give a conclusion about the child's growth without looking at the previous growth pattern. Okay, so always ask for a Septal chart and compare what the previous growth recordings were, and then comment about that, right? Never try to comment about the child's growth only using a single value. You always have to check with the previous values. And now we'll see what.
Excuse me, sir. Sir, we can't hear.
This is very important. Now, what she said was, because the child is calm and quiet, she is going to go for the auscultation first and do the rest of the examination. Now, in cardiovascular system and respiratory system, in infants, right? In cardiovascular and respiratory system in infants, you can always start with the auscultation. Okay, there's normally we do the examination in a set pattern, right? We will first go for the inspection, palpation, percussion and auscultation. But in pediatrics, it's different. In any time, if you think the child is calm and quiet, you can jump the order and finish that as soon as possible before the child starts to shout. Okay.
Excuse me, sir.
Okay. So what is she doing now? The examiner. Why is she holding the brachial pulse while auscultating? Yes.
So to see if it's a systolic or a diastolic murmur?
Yeah, that is to time the murmur. Now, important, when you are doing your adult examination, you usually go for the radial pulse sometimes, right? But in children, never go to the radial pulse. If you want to time the murmur, either check the brachial pulse, or if you can't feel the brachial pulse, go for the carotid pulse. Okay. So if you hear a murmur, either try to check with the brachial pulse or go to the carotid pulse. And as you saw before, this 4-area auscultation is very important, right? First here, the mitral region, and then the tricuspid, pulmonary, and aortic region, right? And as soon as you hear a murmur, always try to see whether it is diastole or systole. Or if you hear the murmur throughout the cardiac cycle, then you can term it as a pan-systolic murmur. What is she auscultating now? What area? Yes. This is especially in small children, you have to auscultate this area. Maybe not in adults, but in children, definitely. You get additional marks if you do the auscultation in the subclavicular region. What are we looking for? What murmur? Any guesses? There's a condition only children will have.
So continuous murmur of patent ductus.
Exactly. Yeah. Patent arteriosis. Because in adults you will very rarely hear that. In children, patent ductus arteriosis is very common, especially in little children. Right? Because sometimes some ductus arteriosus will remain patent unless we have done a surgical intervention. So it's always better to look for a PDA murmur in the subclavicular region. Not in older children like 12-year-old, 13-year-old child, you don't need to do this. But in a small one like this, always go for the subclavicular murmur. You will hear a continuous murmur. In very advanced cases of PDA, you will hear a systolic murmur only. Right? When there's an advanced PDA with pulmonary hypertension, the diastole part might disappear. So you will hear only a systolic murmur, but in a normal PDA, it will be a continuous murmur. Excuse me, sir. Okay, so what the registrar have heard is that she can hear the first and second heart sounds clearly, and she is hearing a ejection systolic murmur in the pulmonary region. So what are the differential evidence? Pardon?
Sir, we can't hear any audio from the video, sir.
No, that's right. That's right. So I am actually telling it again because you can't hear the audio. I will be reiterating it. So don't worry. Okay. So what she said was she can hear the first and second heart sounds clearly, and there is a systolic murmur, ejection systolic murmur in the pulmonary area. So what are the differential diagnoses for that finding? Ejection systolic murmur in the pulmonary region.
Pulmonary stenosis.
Good. Pulmonary stenosis. Anything else?
ASD.
ASD. Good. Number 3. You might hear this in a normal child. What do you call that? What murmur? In a child who has no cardiac defect, still you can hear a murmur in the pulmonary region, especially if the child is having a fever or anemic. It's called a flow murmur. Okay. Sometimes in some children during hyperdynamic circulatory conditions like fever, anemia, thyrotoxicosis, the blood flow through the normal pulmonary valve will be too much. Okay. And that therefore there can be a mild turbulence and you can hear a murmur. So especially in children, when you hear a murmur in the pulmonary area, especially when they're having a fever, it's always better to reassess after the febrile illness have settled. Then if you don't hear the murmur, then you don't have to worry. That means you have just heard a functional murmur. But the first 2 answers are correct. If you think there is a ejection systolic murmur in the pulmonary region, the 2 differential diagnoses will be either ASD or either pulmonary stenosis. And then she mentioned that the murmur is ejection systolic murmur, and she said the pulmonary sound or the second heart sound is normal. It's not increased, it is normal. What does she mean by that? Any idea? When can you get a loud second heart sound? We call it the P2 is loud. Have you heard about that term?
In pulmonary hypertension.
Very good. Yes. So if a child has pulmonary hypertension, if the blood flow to the pulmonary region is high, you can get pulmonary hypertension, then the P2 will be loud. So whenever you hear a murmur, it is better to say whether the second heart sound is louder or not. Because in pulmonary stenosis, the second heart sound will never be loud. Because in pulmonary stenosis, the blood flow to the lungs are less. Therefore, they can't get a pulmonary hypertension. Okay. But in ASD, in atrial septal defect, there is a left to right shunt at the atrial level. And this left to right shunt, if it is a big ASD, large ASD, the left to right shunt will increase the pulmonary blood flow. Therefore, in a large ASD, you can hear a loud P2, but in a small ASD, the P2 may be still normal because the blood flow is very minimal. So this child, the registrar said it's a ejection systolic murmur with normal second heart sound. Therefore, it is either a pulmonary stenosis or a small ASD. Have you any queries up to now, or do you clearly understand up to now? Anyone who have a problem, you can ask me.
So why did you say it's a small ASD, sir?
Yeah, because if it's a large ASD, there will be a lot of blood going from left heart to the right heart. Okay, the left atrium to the right atrium, and the right ventricular blood will also become larger in amount, because there will be blood coming from the right atrium, which they receive from the superior vena cava and inferior vena cava, plus another blood flow from the left atrium to the ASD. So the right ventricle have a lot of blood. Therefore, the blood flow through the pulmonary region will be more, and that can end up with pulmonary hypertension. But when the AST is very small, the blood volume which is going from the left atrium to the right atrium is very minute or very small amount, which is not enough to cause pulmonary hypertension. So they will have the murmur, but they will not go into pulmonary hypertension. Okay. Are you clear?
Yes, sir.
Yeah. When you compare the AST and VST, who will get higher chance of pulmonary hypertension? Atrial septal defect or the ventricular septal defect? Any guesses?
VSTs?
Yes, because of two reasons. Now, in the VST, the blood flow is normally the blood flow is very high, not because of the defect only. You can have a large defect, but remember in VST, it's a high pressure shunt. So the flow is also high, and the pressure with the flow which is ejected is also very high. So VST is a very, it can produce hypertension at an early stage compared to atrial septal defect. Okay. Right. We'll go to the video again. Right. The other things which she mentioned was it's the ejection systolic murmur in the pulmonary region, normal second heart sound, and no splitting. Okay. That is also important because if you hear a split, then it can be an atrial septal defect. You will never hear a split in pulmonary stenosis. So at the moment, this looks like a child with a pulmonary stenosis. At the moment, all the data are towards pulmonary stenosis rather than atrial septal defect. Now she is looking for Balloc and cyanosis. What can you observe? I know it's not very clear, but can you observe any abnormal findings? Especially in this, you can see that the nails are slightly blue in color. Okay, slightly blue in color, and the nails are concave as well. Sorry, convex. So what is this child having?
Clubbing and cyanosis.
Clubbing and mild cyanosis. Right? So cyanosis and clubbing. So, and also in the video it was not clear, but when you look at the mouth, even the oral cavity, their cyanosis was present. So this child is having a cyanotic heart disease with ejection systolic murmur, which is compatible with the pulmonary stenosis. Now, if it was a simple pulmonary stenosis, will the child get cyanosis? Just pulmonary stenosis. Can the child get cyanosis? Yes or no? Think?
No, sir.
No, it never. In a simple pulmonary stenosis, you will never get cyanosis because the only problem in pulmonary stenosis is that the blood flow to the lung will be less. To get a cyanosis, you need to have a right to left shunt. Okay. To get cyanosis, you need to have a right to left shunt. So that means in addition to the pulmonary stenosis, this child might be having another lesion, which is shunting blood from right to left. So we will find that later. Okay. So there was grade 1 to 2 clubbing. Remember, there are 4 grades of clubbing. At this age, it is very rare to find grade 3 or 4 clubbing. Usually you will come across grade 1 to 2 clubbing. When the child grows older, the clubbing can become more and more prominent. So in children, especially infants, you have to be very careful. Otherwise, you will miss grade 1 clubbing if you are not careful. Now she's checking for all the pulses. So first is radial pulse. Now observe carefully. She was checking both brachial pulses and radial pulses together. That's a good way of examining. Whenever you are checking for pulses, always try to do the pulses on both sides of your body at the same time, because at that time you can save time. Otherwise, if you try to do it one at a time, you will spend a long time checking for the pulses. But by doing it in a parallel fashion, you will save time. The second is by checking the pulses in a parallel fashion. That means both sides together. If there's a delay, like a radial delay, you can catch that quickly. Okay. So it's very important not only to check all the pulses, but also to compare the right side pulse with the left side pulse. She's now checking for femoral pulse, both sides again. Dorsalis pedis, again check both sides. See, compare one side. Right, now this is the most important thing after you check all the pulses. So she checked the radial, brachial, femoral, dorsalis pedis. Then sometimes in a bigger child, you can check popliteal pulse as well. But if you can feel the dorsalis pulse, popliteal pulse should be okay. And then you have to request to check the blood pressure. Okay, it's better if you can check the blood pressure, but in an exam situation. I'm talking about exam. You have only 10 minutes. So you have only 7 minutes for do the full cardiovascular system examination. So if you are running out of time, you don't need to check the blood pressure. At least request to check the blood pressure. Then we might give you the findings. Okay. Especially in a child like this, we will never ask you to check the blood pressure because it's a time-consuming thing. But at least you need to request to check the blood pressure. In this child, can you still not hear what's being told, or can you hear the video clearly now?
We can't hear, sir.
Can't hear. Okay, so then I will tell what's going on. Now what she's doing is she's going for the inspection of the chest. So in the inspection of the chest, you need to see whether the chest is symmetrical, and you have to check for surgical scars. Now in a child with a cardiac problem, you will see 3 main scars. One common scar is the midline sternotomy scar. Okay, so if you see a scar like this in the midline, it's called a midline sternotomy scar. Or you might see a lateral thoracic scar. It's the second one you see, lateral scar. So midline scar, lateral scar, and very important, especially if the child has undergone a PDA repair, always look at the back because the scar will be at the back, right? Parallel to the scapula. So it's a subscapular scar. It's again a lateral thoracic scar, but it will be at the back of the chest. So when you're looking for scars, look at the front, but remember to look at the back as well. And you can see for a visible apex, that means whether the apex beat is visible. It may be either on the left side or right side, because you might get children with dextrocardia. And then finally look for deformities of the chest. Can you name 2 common deformities of the chest children have? Anatomy. Any anatomist? Common deformity. Yeah.
Pectus excavatum and pectus
Pectus
carinatum.
excavatum and pectus carinatum. Yeah. So those are two common deformities. The other common deformity is sometimes in children with chronic obstructive lung disease, you might get a Harrison sulcus, right? Not in this age. Usually you commonly see in an older age. Okay, so we have hyposymmetry, scars, visible apex, and deformities. This child has none of the deformities. Now we are looking at, okay. So this is the lateral scar in the posterior region, which I was mentioning. So there are no scars. Now she is going for the palpation. And the two common things you need to remember in palpation is first palpating the apex beat. And this is the correct way of looking for the apex beat. You always use both hands and check both sides, because you never know, this may be a child with dextrocardia. So if you check only the left heart or left side of the chest, you might miss the apex in the right side in a child with dextrocardia. So any child, whether they are small or old, always go with your both hands, even in adults, right? There are so many adults with sometimes undiagnosed dextrocardia. So always better to go with both hands, feel for the pulse. Once you feel on one hand, remove the other hand. Now she has got apex on the right side. She's now looking at the out. Once you localize the apex, you need to count the ribs and find out whether it's in the 4th intercostal space or 5th intercostal space. And also draw a line from the midclavicular line, okay, the midclavicular line, and see whether it is lateral to the midclavicular line or medial to the midclavicular line. So she's counting 4th intercostal space in the midclavicular. So if the candidate got the apex in the left side, 4th intercostal space, midclavicular line. Is it a normal apex or a shifted apex? This is an infant. Normal or shifted? Yes? Any idea?
Normal.
Yeah, it's a normal apex, right? In children, normally we expect the apex to be in the 4th intercostal space. If it has gone down to somewhere around 5th or 6th, or if it is shifted away from the midclavicular line, then we have to worry whether there is a left heart hypertrophy. But this child does not have a left heart hypertrophy, and the apex is in the normal position. Okay, so now we know this is a child with cyanosis and clubbing. So it's a cyanotic heart disease. There's a murmur in the pulmonary area, which looks like a pulmonary stenosis, but it can't be an isolated stenosis, because isolated pulmonary stenosis will not cause cyanosis. So this must be, there might be some other defects as well. And the apex is normal. That means the left heart is not hypertrophied. So these are the findings we have gathered up to now. A cyanotic heart disease child with normal left heart and a pulmonary stenotic type of murmur. And other findings we know is that the child is very comfortable lying down in bed, And do you think the child is in heart failure or not? By looking at the child, and you have observed this child for the last 5 minutes, do you think there are any features of heart failure in this child or not?
No, sir.
No. And do you think there are growth failures? No, because the child looks adequately grown, very comfortable in bed, no features of heart failure. So these are the findings up to now. So we'll go through the rest of the and see what she finds. Now she is looking for, not looking, she's feeling for palpable heart sounds. Okay. Or in other words, cardiac thrills. Okay. So she first checked the apex region. Now she's checking the sternal region for thrills. And what she commented was she can't feel any thrill. Okay. So the murmur she heard is a ejection systolic murmur, but there is no thrill. So the grading of the murmur is grade 3. Okay. Grade 1 is very difficult to hear murmur, very subtle murmur. Grade 2 is somewhat easy to hear. Grade 3 significant murmur without thrill. Grade 4 is a murmur with a thrill. So this child either has a grade 2 murmur or grade 3, but definitely not 4, because the child does not have a thrill. Now what is she looking for? She has put the 4 fingers at the side of the sternum. And what is she looking for?
Parasternal heaves.
Parasternal heave, excellent. And she did not find any heave as well. There's no parasternal. Now she's auscultating the lung bases. Okay. Now we said that yes, it is very unusual for the child to have heart failure because she is behaving very well, no features of distress. But it's always better to check the lung bases and see whether there are crepitations, fine crepitations, which might again indicate whether the child has a cardiac failure or not. Sure. So she's checking both lung bases, and both lung bases are clear. So what are the other features you would check in a child with heart failure? One is the behavior and whether the child is distressed or not. Number 2, lung bases. But in an infant, there are some other important things which should come before the lung bases. Can anyone list them down? There are 3 other features in an infant with heart failure. Yes?
Breathlessness.
Breathlessness, okay. Or we'll say tachypnea. Okay, the tachypnea, number 1, good. Number 2?
Hepatomegaly.
What hepatomegaly?
Tender hepatomegaly.
Tender, yes, tender hepatomegaly. Okay, so just hepatomegaly may be due to sometimes child with bronchiolitis might have a push down liver, right? But if it is tender hepatomegaly, it is very important. And regarding the pulse, what is the other thing which will tell that the child is in heart failure or not? What rhythm?
Gallop rhythm.
Gallop rhythm.
Gallop rhythm. So the features in an infant with heart failure, the first you can divide it into signs and symptoms. Okay, the symptoms will be, the mother might say the child is having difficulty in feeding. Okay, feeding failure, or the mother might complain that the child is excessively sweating during feeding. Okay, and the child is very restless. Child doesn't like to stay in the lying down position, but the child becomes comfortable when the child is kept at a upright position. So those are the symptoms the mother might tell you in your history taking. The signs or the features will be gallop rhythm, tachycardia and gallop rhythm, tachypnea, tender hepatomegaly, and sometimes fine crepitations in the lung bases. And if you are going to look for edema, where will you check for edema in this child?
Sacral edema.
Sacral, yeah, because this child obviously is not walking. So unless the child has a major significant generalized edema, he will not develop edema in the ankles. The best area to check for edema in this child is the sacral region. Okay. Okay. So these are the heart failure, tachypnea, tachycardia, and hepatomegaly, gallop rhythm, sacral edema, and lung base crepitations. She's going to check. She's checking for the. Is that technique correct? I know it's a registrar, but you can comment on that. Is that technique correct or wrong? The technique of looking for hepatomegaly. That was actually not the correct technique, because she was pressing down and quickly taking the hand down. Too fast. We'll go back and see. Okay, now we'll see again. Right. That is, see, that technique is wrong. First, her hand is not parallel to the abdomen of the child. She is coming from a superior position. So first of all, you have to do is you need to bend down or come to the level of the child. You might have to kneel down beside the bed and keep the whole hand parallel to the abdomen. Okay, and your board of this hand, right? Your radial board of this hand should be parallel to the board of the liver, not only the fingers. Now she's pressing down only with the fingers. And the other thing is, once you press down, you need to wait and let the liver come and touch you and go. That's how you feel for the liver. You are not going to push and look for the liver. You push down and wait and see whether you can feel the liver coming and meeting your hand and go back again, right? So if you keep pushing like this, sometimes soft livers might be pushed inside and you might not pick the liver properly. You might not locate the liver properly. So you have to be very gentle, but at the same time, very patient when you are looking for a liver. Okay, so now she will be going for the presentation, but we will stop from there. Okay, so we'll go to the findings again. Give me 1 minute. Light source and come back to you. Okay. So up to now, what the findings what we had was it was an infant who was lying down comfortably in the bed, and the child was having cyanosis, clubbing, mild degree cyanosis and clubbing. And there were no features of heart failure. The growth seems to be adequate. There was a pulmonary stenosis murmur, right? But it can't be an isolated pulmonary stenosis because the child is having a cyanosis as well. And there are no features of left heart hypertrophy because the apex was in the normal position. And there is no pulmonary hypertension because the second heart sound is normal. Okay. And there were no other abnormalities like dysmorphism in this child. So what are the cyanotic heart disease you know, first of all? Can you name one or two cyanotic heart diseases?
Fallot's tetralogy.
Yeah, tetralogy of Fallot. Okay, that is one. Anything else? Anything else? One is Fallot, the other. Have you heard of truncus arteriosus? Yes. And there are so many other complex cyanotic heart diseases, but the only condition which you as fourth year or final year medical students to be aware of is tetralogy of Fallot, okay, or Fallot's tetralogy. Now, does this child match Fallot's tetralogy? What are the four? Now, tetralogy means there are four problems. So, what are the four problems a child with tetralogy of Fallot has? Okay, someone has a transpersion of great arteries. Yes, that's another common cyanotic heart disease. So, what are the four features of tetralogy of Fallot?
There will be a large VSD and overriding aorta.
Overriding aorta. Because the
Pulmonary
overriding aorta,
stenosis.
because the aorta is overriding, the pulmonary artery will be stenosed. Okay, so pulmonary stenosis, aortic overriding, ventricular septal defect. The last one, there will be some degree
right ventricular hypertrophy.
Yes, there will be some degree of right ventricular hypertrophy. Okay, so we'll take that and see whether we can match that diagnosis to our child. Now, in tetralogy of Fallot, the right ventricle is hypertrophied, but not significantly hypertrophied at this age. It will take long time for the right ventricle to hypertrophy to produce a parasternal heave. That's why this child did not have a parasternal heave. And in tetralogy of Fallot, it's a right heart problem. The left heart is fairly normal. Therefore, that's why we had a normal apex beat in this child. And the other thing, now if you have a ventricular septal defect, what happens is there will be a left to right shunt. And what murmur should you hear if there's a purely a ventricular septal defect?
A pansystolic murmur.
Pansystolic murmur, because there will be blood going from a high pressure left ventricle to a low pressure right ventricle. Now in tetralogy of Fallot, although there is a large ventricular septal defect, you will not hear a pansystolic murmur. The simple reason is in tetralogy of Fallot, the aorta is overriding. Aorta overriding means both right ventricle and left ventricle is now supplying the aorta, because the aorta has jumped the line. It has gone from the left ventricle towards the right ventricle, compressing the pulmonary artery. And when that happens, the right ventricle has to hypertrophy to meet the demands of the aorta. Therefore, the pressure in the right ventricle will also be high, and it will be almost same to the left ventricle. Therefore, although there is a large VSD, large ventricular septal defect, the left to right shunt will be minimal. To create a murmur from a large VSD, you need a very high flow. But in children with tetralogy of Fallot, because the right ventricular pressure and left ventricular pressure are almost same, the flow is minimum. Yeah, that's why we don't hear the murmur. And the only murmur we hear is when the blood go through the pulmonary stenosis, the stenosed pulmonary artery. So that's why, although tetralogy of Fallot, they have a VSD and a pulmonary stenosis, the murmur you hear will be only the pulmonary stenosis, not the ventricular septal defect. Therefore, this child, what the child we have been examining, is actually having a tetralogy of Fallot. And tetralogy of Fallot, they will never go into heart failure. That's the other cardinal thing. You have to give me 1 minute because the electrical source is not very stable here. Give me 1 minute. Okay, hope I have got this right. Yeah, problem sorted. Okay. Any questions from that description? Any questions which you are not clear of? Or any queries?
So when does the apex reach the fifth intercostal space?
What are the conditions? Oh, you mean what
No,
age?
sir.
The normal?
Yeah.
There's no particular age, but usually when the child is somewhere near adolescence, yes, you might find the apex somewhere around fifth intercostal space, right? But normally in children, especially preschoolers before 5 years, the apex is usually found somewhere near in the fourth intercostal space. In school age children, if you find apex in the fifth intercostal space and the child otherwise is perfectly normal, then you can say it's a normal apex. Okay.
Thank you, sir.
Yeah, just because the apex is in the fifth intercostal space, that doesn't mean the child is having left ventricular hypertrophy. There should be other features as well. So the apex should be heaving, okay, and there should be other evidence of cardiomegaly before you comment on whether the apex is abnormal or not. Just the place is not enough. You need to fulfill the other findings as well. Okay, then there's a question. Why a patient with tetralogy of Fallot cannot go into heart failure? Yes. Is there anyone who can answer that? If you have a, when the problem is now, in tetralogy of Fallot, what happens is, there is, in VST, if you take only a VST without tetralogy of Fallot, if you just take a VST, there will be a left-to-right shunt with a high flow, right? I'm talking about a normal child with a ventricular septal defect, not tetralogy of Fallot. So in a VST, there will be a left-to-right shunt with a high flow, and the right heart will not be able to handle this high flow. Okay, that's why he go into failure. The right heart go into heart failure because the right heart can't handle the high flow. Okay? And the only place where it can push blood or pump blood is the pulmonary artery. Okay, so in a child with ventricular septal defect, the right ventricle is in trouble because there's only one way he can push the blood, that is into the into the lung through the pulmonary artery. And he's getting blood in a very high flow, which the right ventricle is not used to get. The left ventricle, on the other hand, is a very high muscular organ, which can handle high pressures, but not the right ventricle. So in a child with purely ventricular septal defect, when there's a left to right high flow, and also the output also is limited by the pulmonary artery, the right ventricle can go into failure. And we call that right heart failure. But in tetralogy of Fallot, because the aorta is overriding, the right ventricular pressures and the left ventricular pressures are almost same. Okay, therefore the flow is minimal. There is a big VST, but the flow is very low. And also the right ventricle can push blood not only towards the lung, but also it can go through the aorta and release the pressure inside the right ventricle. Because the flow is slow, the right ventricle have time to adapt by hypertrophy. Therefore, they don't go into heart failure, right? Because the flow is very low, the right ventricle have time to adapt by hypertrophying slowly over the time to prevent the child from going into heart failure. In a VST, the right ventricle does not have enough time because the flow is very fast and it doesn't have time to adapt. So that's why children with VST will go into heart failure, but in children with Tetralogy fellow who also have a VST does not go into heart failure. And there's another question, can't we hear 2 heart murmurs in Tetralogy fellow in any age? No, usually it's very unusual to get 2 murmurs in Tetralogy fellow unless the child has developed some other cardiac condition. Like for example, we had a child with Tetralogy fellow who had rheumatic arthritis and his mitral valve was damaged. So therefore the child had dual murmurs, but normally it's a single murmur. There's another question. How is a child with Tetralogy fellow presenting initially? Well, children with Tetralogy fellow, do they present with cyanosis at birth? Is it common or uncommon? Children with Tetralogy fellow, we'll say it's MCQ. Commonly presents at birth with cyanosis. Any answer? No. Okay, there's answer saying no. Anyone who says yes? Okay, no one. Yeah, answer is correct. The Tetralogy fellow initially in the first week, sometimes you might not detect significant cyanosis. So children with Tetralogy fellow, there's a high chance to be discharged home without the cyanosis being noted. And normally in the second week or third week, when they come to clinic follow-up, you pick the cyanosis and then investigate. Okay. And also in early newborn period, the pulmonary there is a physiological pulmonary hypertension. Okay. In the early newborn period, there is a physiological pulmonary hypertension. Because there is a physiological pulmonary hypertension, which will settle over time, which will settle over about 2 or 3 days. So in the initial period, the blood flow from the right ventricle through the stenosed pulmonary artery to the lung will be a little bit low. And because this blood flow is low, it is not enough to cause a murmur. Okay, so the pulmonary stenosis murmur will be not very clear soon after birth. With time, when the blood pressure in the lungs are settling, you may start to hear the pulmonary stenosis murmur. So Tetralogy fellow is sometimes easily missed at birth. But on the contrary, the other condition, transposition of great arteries, they are almost always picked up at birth because in that condition, cyanosis occurs at a very early stage. So it is very unusual for a transposition of great arteries child to go home unnoticed, but it is not uncommon for a Tetralogy fellow child to go home without being picked. Okay. There's another question. Does the 4 abnormalities appear simultaneously in Tetralogy fellow? Does the 4 abnormalities appear simultaneously in Tetralogy fellow? No. Normally in Tetralogy fellow, what happens is there is aortic overriding. Okay, there is aortic overriding, which usually happens with pulmonary stenosis. And what happens during cardiac, in fetal anatomy is because the aorta is overriding, the right ventricle, if there is no VST, a child with a Tetralogy fellow cannot survive. Okay, because the right ventricle will keep on supplying only cyanosed blood to the aorta. So what happens is the aortic overriding occurs with the pulmonary stenosis. Later on, there will be a VSD developing to get the left ventricle blood back into the right ventricle and through that to the aorta. So it's a complex procedure, but in exam, we will never ask which comes first and which comes last. If you can remember, these are the 4 defects in Tetralogy of Fellow. That is more than enough. What about the blood pressure in this baby? Normally in Tetralogy of Fellow, blood pressure is normal. Okay, there it will be normal. So in infants less than 1 year of age, normal blood pressure will be somewhere around 90/60. Okay, systole is somewhere around 90 to 100 in a normal infant, and diastole in a normal infant is somewhere around 60 to 65. What are the other common heart diseases we can find during pediatric sessions? Okay, the common heart diseases you will come across in your pediatric appointment, the most common will be ventricular septal defects. Okay, acyanotic heart disease are common compared to the cyanotic heart disease. Acyanotic heart disease, as medical students, you need to know thoroughly about ventricular septal defect. You need to know thoroughly about atrial septal defect, and you need to know about patent ductus arteriosus. These are the 3 things which are commonly occurring, congenital ones. There are other varieties which you can know, but we will not, deeply ask questions about that. Acquired heart diseases, mitral stenosis and mitral regurgitation, and also aortic stenosis and aortic regurgitation, because those are the 2 common diseases associated with rheumatic carditis. Out of the congenital heart disease, if you know something about Tetralogy of Fallot and transpersion of great arteries, that is more than enough. Wait, there are now so many questions. What are okay? Is that due to closure of ductus artery lead to minimize mixing blood? I did not get that. Is that due to closure of ductus arteries lead to minimize mixing blood? Well, I'll come to that later. Elevated JVP, a sign of heart failure in infants. Well, in children, we don't usually check jugular venous pressure. Especially in infants, we never check because it's very difficult. So in adult medicine, yes, you need to concentrate on jugular venous pressure, but in infants, you are never supposed to look for even jugular venous pressure. Okay. What are the complications the child can develop if this condition is not treated? Okay. I can ask that question again from someone in the audience. If you do not treat Tetralogy of Fallot, what are the complications you can get? That's a very good question. Okay. Anyone who would be happy to answer that? Yes, Mr.
Infective endocarditis.
Infective endocarditis. Okay, that is one. But more common than that? Remember, it's a right to left shunt. So any septic focus in the blood which is coming to the right heart can directly go through the shunt to the left heart. And this septic emboli can be distributed anywhere in the body, commonly the brain. So you can get sometimes brain abscesses in uncorrected cyanotic, any cyanotic heart disease. And not only for Tetralogy of Fallot, if you do not correct cyanotic heart disease, you can get abscesses, brain abscesses from septic focus in the right side of the body or right heart circulation, because normally what happens is when septic emboli comes to the right side of the heart, it will be pumped towards the lung, and there are pulmonary macrophages which will destroy the septic emboli. Okay, but in children with cyanotic heart disease, because there's a right to left shunt, the pulmonary circulation can be bypassed, and the septic emboli can easily go from the right heart to the left heart and then shoot into the cerebral circulation and end up as the cerebral abscess. So in cyanotic heart disease, cerebral abscess are very common. The other condition is if a cyanotic heart disease is not corrected, what happens is the child will be chronically hypoxic, right? Child will be in chronic hypoxia. And when you are having a chronic hypoxia, you will get polycythemia. Okay, the body will try to compensate by creating a polycythemia, right? Because when you have a cyanotic heart disease, you have deoxygenated blood circulating in the arteries. And to increase the oxygen carrying capacity, the body will try to produce more and more red cells. And you will end up with polycythemia. And in a condition, especially in conditions like diarrhea and vomiting, when the child is dehydrated, the polycythemia can lead to thrombotic events. Okay, conditions like cerebral vein thrombosis, okay, renal vein thrombosis can occur in a child with a cyanotic heart disease who is having polycythemia, especially triggered by a dehydration event. So those are the complications which a child can develop when they have an uncorrected cyanotic heart disease. Why do we get the splitting of the second heart sound in ASD but not in pulmonary stenosis? Yes, it's actually not splitting, it should be fixed splitting. Because during inspiration, you get a splitting, but in expiration, you don't get the split. In a normal child, what happens is in inspiration, yeah, anyone can answer that? Why splitting in ASD but not in pulmonary stenosis? Does anyone know about this? Can someone try? Why splitting is present in a ASD but not in a pulmonary stenosis? Second sound, there are two components, right? What are the two components?
Pulmonary and aortic.
Pulmonary valve and the aortic valve. So in inspiration, what happened? The blood flow to the heart will be more. Okay. In inspiration, there's a negative pressure. And therefore, what happens? There will be more blood coming to the right heart. And in expiration, so inspiration, more blood coming to the right heart. So the pulmonary heart sound will be, pulmonary valve will close a little bit later than the aortic valve. During expiration, this happens simultaneously. Therefore, during inspiration, you might hear a split, but during expiration, the split is not heard. So this is called a physiological splitting. Okay, but in atrial septal defect, what happens is there is all the time blood going from left atrium to the right atrium. Okay, whether it is inspiration or expiration, it doesn't matter because there's a hole, and all the time there will be blood going from left atrium to the right atrium. So right atrial blood flow will be all the time high, regardless whether it is inspiration or expiration. Because the right atrial blood pressure is all the time higher than the left atrium, the right ventricle blood flow will be always higher, and the pulmonary heart sound will close always later than the aortic sound. So that's why the split is fixed throughout inspiration and expiration. Right? In pulmonary stenosis, there is no ASD. So there is no blood flow within the atria. Therefore, in pulmonary stenosis, there is no fixed splitting. I hope I answered your question. Then there is another question. So can't we see any ECG abnormalities in tetralogy of Fallot? Yes, there can be ECG abnormalities. If there is significant right ventricular hypertrophy, then there will be right side leads. There will be changes in the right leads, right? There will be some changes like right axis deviation in tetralogy of Fallot. Any question? Yes? Okay. If the child with tetralogy of Fallot go home unnoticed, then what symptoms make them visit the hospital again? Yeah, usually when they go home, there will be no cyanosis, but after about 1 to 2 weeks, the child will start to develop cyanosis. Or sometimes with crying, the cyanosis will increase. That's the time when the parents see that there is something unusual and bring the child back to the hospital. Okay. Normally they will say Andanakota nil and then settle down again. What heart diseases get low isolated diastolic pressure? The most common heart disease to get a low isolated diastolic pressure is aortic regurgitation. Then can't ejection systolic murmur due to pulmonary stenosis and diastolic murmur due to overriding aorta occur in tetralogy of Fallot? No. Normally it will not occur. You might, theoretically it can occur, but the ejection systolic murmur is the best heard murmur in tetralogy of Fallot. Then does Eisenmenger syndrome common in children? How will they present? Very uncommon in children, because to get Eisenmenger means left to right shunt has become reversed and now it is functioning as a right to left shunt. And for a left to right shunt to become reverse, there should be significant pulmonary hypertension developing. Significant, yes?
Oh.
Hello? Oh, okay, sorry. So for a left to right shunt to reverse back into a right to left shunt, you need significant pulmonary hypertension to develop, and this happens over a prolonged period of time. So normally we see Eisenmenger in, like, say, in second decade or third decade, not definitely in children. Okay. But anyway, these days we don't see Eisenmenger commonly because most of the heart defects are picked up and surgery is done at an early stage. Why some heart disease becomes cyanotic and others not? That all depends on whether it's a left to right shunt or a right to left shunt. Any heart disease with a right to left shunt becomes cyanotic. Any heart disease with a left to right shunt becomes a acyanotic heart disease. Pulmonary congestion. What is the difference between pulmonary congestion and pulmonary hypertension? Well, pulmonary congestion is a very vague term. You can use it for acute, even during an acute condition like pneumonia, you can get pulmonary congestion. But when you say pulmonary hypertension, that means we are talking about the hemodynamics of the pulmonary vasculature. Okay. Why S-wave absent in ECG of tetralogy of Fallot? S-wave absent in ECG of tetralogy of Fallot. You mean in the right heart leads, right leads, or the left leads? Yes. Because to get S waves, you need to have left ventricular hypertrophy. But in tetralogy of Fallot, you don't have left ventricular hypertrophy. Yeah. So in right leads, there is right ventricular hypertrophy. So you can't get a S wave there. If I think that is the answer, but I will double check and let you know. I'm not an expert on ECG. Okay. Increased cyanosis with crying seen in all cyanotic heart disease? No, not all cyanotic heart disease, but in most cyanotic heart disease, especially tetralogy of Fallot. Right, that's a very common condition. Increased cyanosis with crying, especially in tetralogy of Fallot, but even in any congenital heart disease with cyanosis, you can see this condition. How to manage tetralogy of Fallot baby in the hospital? Well, there is no special management. The definitive treatment is to go for an early cardiac surgery. Important things you have to tell for a mother with tetralogy of Fallot is they can get hypercyanotic spells, right? Has anyone heard about this condition, hypercyanotic spells or TET spells? Yes or no? Hypercyanotic spells. it's a condition where the child will go into, child with a cyanosis sometimes will end up with deep blue cyanosis. So there will be a significant increase in the intensity of the cyanosis, especially after a period of excessive crying. Okay, that happens commonly with children with tetralogy of Fallot. We call it a hypercyanotic spell. It's a medical emergency. What happens is the pulmonary infundibulum or pulmonary artery, the infundibulum can go into spasm, and pulmonary blood flow will completely be cut down. And then what happens is the right ventricle have no option, because he can't pump blood to the pulmonary artery, because now the pulmonary artery has undergone spasms. So pulmonary blood, so the right ventricular blood will now directly go into the aorta, totally go into the aorta, bypassing the pulmonary artery. And then the child will end up with a hypercyanotic spell, completely deoxygenated blood entering the aorta. Okay, that's a medical emergency, and there are maneuvers. There are certain maneuvers which will reduce the spasms, and the most common maneuver is putting the child in knee chest position. If you read some books, you might come across this word, the knee chest position or the frog position. Right? Or there are certain drugs which we can give, like morphine, to reduce pulmonary spasms. So that is how you manage. The other thing is, in a child with cyanotic heart disease with diarrhea and vomiting, you need to give a lot of prominence or lot of priority for rehydration, because if a child becomes dehydrated, they can end up with a thrombotic event. Pulmonary congestion and consolidation the same? No, wrong. Consolidation is termed only in a condition, mainly in conditions with a pneumonia, right? But pulmonary congestion sometimes you can get with asthma, in a child with asthma, or in a child with pulmonary hypertension. So consolidation, when you say consolidation, you are talking about alveolar damage. So usually we use this name when we are saying there is a child with a pneumonia. When you say pulmonary congestion, you are talking about the blood vessels, not about the alveoli. Can TOF be diagnosed antenatally? Certainly, yes. If normally we do an anomaly scan, that is at 21 weeks, and sometimes you can pick up a child with tetralogy of Fallot during the antenatal scans. Not always, but you might be able to pick it up. Right, last question. Okay, because I have to leave now. It's already 20 minutes late. What is Balloc procedure? It's not Balloc, it's called BT shunt, Balloc-Taussig procedure. Okay, so Balloc procedure or BT shunt is now, but the problem in tetralogy of Fallot is there is a pulmonary stenosis and blood flow to the lung is less. So some of the blood will go to the lung, and the rest of the right heart blood will go to the aorta, because the aorta has overridden. Okay. In significant pulmonary stenosis, in children with tetralogy of Fallot will have various degree of stenosis. Some have mild stenosis, some have severe stenosis. So when severe stenosis is there, the child will get less blood flow to the pulmonary vasculature, and then the child will not grow properly, because the child will not get proper oxygenated blood. You will get proper oxygenated blood only if the blood goes to the lung in a proper manner. So what we do is we can create a shunt to improve the pulmonary blood flow. So Balloc-Taussig procedure, BT shunt, is what we do is we put a shunt between the right subclavian vein and right pulmonary artery. So the blood which is coming through the subclavian vein, rather than going to the inferior vena cava and going to the right heart, it will directly flow to the pulmonary vein. So all the blood, or most of the blood in subclavian vein, will be directly shunted towards the pulmonary vein to improve the pulmonary circulation. So this is called BT shunt. All you need to remember is it's a shunt to improve pulmonary blood flow, but it's only a temporary shunt. It is not the corrective cardiac surgery. You do that shunt until, to buy time until the child is big enough to undergo the proper corrective surgery. So could you please explain about development of pulmonary hypertension? Okay, I will tell that and then we will stop for today. What happens is when the pulmonary blood flow, now for the lungs to function properly, lungs means the alveoli and the lung capillaries to function properly, blood should enter the pulmonary circulation in a predetermined flow, right? In a predetermined volume. If there is a cardiac condition which is unusually increasing either the flow or the volume of the blood which is entering the pulmonary circulation, if that persists for a long time, then what happens is the capillaries which are designed, capillaries and arterioles which are designed to handle a low pressure, low volume, will be now exposed to handle a high pressure or a high volume of blood over a long period of time. Therefore, to adapt to this high flow and high pressure for over a long period of time, blood pressure will, the pressure in the pulmonary artery will slowly increase. It is similar to what happens in systemic circulation as well. Because if a person have a hyperdynamic circulation or unusually high flow or high volume, which is maintained over a period of time, we can get systemic hypertension. Same way, you can get pulmonary hypertension if the pulmonary blood flow is either occurring at a higher flow or higher volume for a longer period. Then should we give infective endocarditis prophylaxis in? Yes, cyanotic heart disease children, infective endocarditis prophylaxis can be given for significant cardiac conditions, but there are recent changes in guidelines. Each and every cardiac disease does not need endocarditis prophylaxis. For example, atrial septal defects, you don't need to give infective endocarditis prophylaxis, but in conditions like mitral valve disease, severe mitral valve disease, and ventricular septal disease, you might have to use. Okay, I think we will stop for today. I was supposed to stop at 11, but now it's 11:23. I have another commitment at 11:30. I'm very pleased because you have posted a lot of questions. I hope I have answered all these questions, but there may be some areas which I was a little bit not clear. So I will go through the questions. And if there are areas which are not clear, I am happy to give a feedback again later. Especially the ECG questions. I'm not an expert on ECG, that's why. So I'll go through those ECG questions and get back to you later. Okay, so I'll try to produce, there are some other videos. So I think it's better to show you a video and explain it rather than giving a detailed account. Do you think this type of video presentations are helpful?
Yes, sir.
Yeah, okay. So I'll try to do some more videos and then present it to you. Okay, so we will stop the class for now.
Thank you, sir.
Okay.
Thank you, sir.
Can we have sessions weekly? It keeps us alive. Okay. Right. Alive means medically alive. Okay. Right.